Good morning, everyone. Well, it's morning for me. This is a quick review for exam one. So I posted these cases a couple of days ago, so we'll go through them and I'll explain my logic here, and you can expect to see some similar test questions. So here we have a case where we have a patient who started a specific birth control called Merced, and she's getting breakthrough bleeding. And so the choices are to continue her current drug or to change to different ones. And I've given you a table of a list of the components of birth control in general form. So basically, I'm not asking you the specific types of androgen or progestin or estrogen, but I'm asking you to understand like how you would maybe change a birth control product to better suit the patient's needs. So in this case, you have breakthrough bleeding, which is a common side effect, and it's usually associated with a low estrogen component. And so in this case, I've given you options with their estrogen components as 2 with low and 2 with intermediate. So if you're trying to make a decision here, keeping the Merced is probably not a good idea. She's having side effects with it now, so why would you continue the same birth control? And so you probably want to switch to one of the intermediate products because a little bit higher estrogen can help stabilize the endometrium and can help prevent that breakthrough bleeding. And so if we're going to do that, you have a couple choices here. So you have Orthocept or Low Estrin are the two brand names I've given you here. And the differences here are a couple. So the progestin component is very high or high. It's similar. So we kind of lump those into the same group. It's not really a big difference there. And then the androgen component is the big difference. So this is really where you're going to make your decision based on which one to pick. And what you'd want to do in most cases is to keep everything the same. So it's the rule of really anything in life, but in medicine specifically in drugs, you don't want to change everything all at once. You probably want to make one change and see how it goes, and then you can change other things. So I don't recommend changing both the estrogen and the androgen product at the same time. So in this case, we can increase the estrogen slightly to the Orthocept product, keep pretty much everything the same, including the androgen activity and the progestin. So B would be the correct answer because of that. Now, if I gave you other side effects like she's experiencing bloating or acne, that might be different, and I might target the androgen, or you might want to target the androgen component specifically. But I gave you breakthrough bleeding, which is very heavily focused on estrogen. So, and again, I'm not going to ask you a lot about specifics for birth controls. I would like you to know a little bit about when you're studying. Hopefully you'd know mechanism of action stuff would be fair game for all of my tests. Ethanol estradiol, being able to recognize that as the estrogen component because it's the constant in most birth control products. So those types of things. But as far as all the progestins, it's just too much to know, and they all kind of sound the same too. But they're all pretty much the same thing with subtle variation. So, okay, hormone replacement therapy. We have a 51-year-old woman with hot flashes, vaginal irritation. She's tried exercise, diet, antidepressants to help relieve the hot flashes without success. She's otherwise healthy, without history of cancer, CV disease, or surgery. She would like to try HRT today due to hot flashes interfering with her daily activities. Which of the following is true regarding combination hormone replacement therapy? And these ones are looking at combined estrogen and progestin products. And this is a pretty basic Chad question, I think. So really just side effects. Remember, anything clotting related, you're going to have a increased risk of usually. So you have an increased risk of stroke. While myocardial infarction is wishy-washy, it's certainly not a decreased risk of it. So at best, it's neutral. So we don't really want to say that. So B is not correct. C, increased risk of fractures. This is actually one of the benefits, is they can decrease and help with prevent osteoporosis. And D, increased risk of DVT. That would be the correct answer. So hopefully that's a pretty easy one. One of the hallmark side effects of hormone replacement therapy, increased venous thromboembolism. Number 2, which of the following hormone replacement treatments is best to recommend in this patient? And we have a couple different options here. So you have Alora, which is a estradiol twice weekly, Climera patch, which is an estradiol once weekly patch. You have Prempro, which is a combination, and Premarin cream, which is estrogen vaginally twice weekly. So a couple things you can eliminate right away. This patient, I gave you specifically that she didn't have any history of surgery. And you can infer with that she hasn't had a hysterectomy, right? Because, of course, you'd have to have a surgical history hopefully listed if you had a hysterectomy in the past. So in this case, your patient has an intact uterus, and that eliminates straight estrogen products. So we don't want to give unopposed estrogen to people with intact uterus. And so that eliminates A and B right off the bat. Now you're left with C and D. So the question is, do you use a topical product or do you use a systemic oral product? And in this patient, you have to look at the symptoms. So if I just gave you somebody with vaginal irritation or vaginal dryness or pain during intercourse, those types of symptoms alone, then yes, a topical preparation might be fine. But she's got systemic vasomotor symptoms, which I've given you in the form of hot flashes. So that would mean that the topical preparation would handle only probably half her symptoms. So we want to target everything, and we're going to give her a combination oral product that's going to be systemic, and that's choice C. All right, LC, we've got a 28-year-old female. She's pregnant. Prior to pregnancy, she used to take Imitrex a couple times a year for migraines, which was effective for her. She's in your urgent care. She's got a migraine. She's taken acetaminophen that was instructed by her OB if she got migraines, and it's just not getting better. She's here for more advanced treatment. So this is just a question of looking at what is the best road we go down for pregnant patients. And really, the concept is of course, doing the least amount of potential harm to the fetus. So we're going to look at what options we have that are sure bet. So acetaminophen is safe. So she did the right thing by trying Tylenol. Tylenol should work quickly. If it doesn't, you haven't really lost much time. Yes, your patient's still in pain, but we need to move on to the next step, and we know that Tylenol didn't work. So that's happened. Tylenol is always going to be your first choice in a pregnant patient just because it can be effective and, again, minimal risk. So you have a couple choices here. Ideally you could give her Imitrex, but we talked a little bit about how Imitrex has some controversy around it. It's not necessarily a total contraindication in pregnancy, but it is something that has some bad animal model data. And while that hasn't necessarily been replicated in humans, it's certainly not a category B listed. So it's something that we could use potentially, but it's not the next step. It's not something we want to try right now. DHE is more potent and generally speaking not used in pregnant patients. So we're going to skip that one. Then that leaves us with our two choices, C and D. D is an NSAID, which again, probably not the best use, especially at 32 weeks pregnant. You probably would want to avoid your NSAIDs altogether at this point. And so that leaves you with C. C is metoclopramide. Metoclopramide is category B. It's an antiemetic. And as we know from our previous lectures, antiemetics do work well for headache, and they are kind of one of the different tiers of headache treatments. So metoclopramide is again a relatively harmless agent we can use in a pregnant patient that has the possibility of restoring her or decreasing her pain that she's experiencing from the migraine. Now, if the metoclopramide didn't work, maybe you could consider triptan, but I'd certainly try the metoclopramide first. So that'd be the next step in an ideal world algorithm. So C is the correct answer on this one. Which of the following medications would be first line for stopping preterm labor in a patient who's 33 weeks pregnant? So this question just requires knowing the algorithm I gave you, and generally speaking, after 32 weeks, we look at nifedipine as our primary agent of choice, first line. That would be the correct answer here. So A, well, I didn't give you letters, but the nifedipine would be the correct choice. Okay, some pediatric stuff. This is a 1-day-old boy, recently spiked a significant fever. He was breastfeeding initially, but has stopped eating. Labs are remarkable for leukocytosis. Vitals show tachycardia and hypotension. His mom has no history of MRSA, but was on prophylactic therapy for group B strep during delivery. Which antibiotic or antibiotic combination makes the most sense to start at this time? So here you have a couple different choices, and some of them might seem a little bit more obvious. So let's see, what can we rule out right away? Remember, Vanco is only for MRSA in these patient populations, just like for adults, and we really don't have any risk for it. I said that there's no history of MRSA. Yes, the patient's in the hospital, but very unusual for a child to see this. And of course, the mother has group B strep listed, so it's something that we're going to be pretty. That's going to be one thing that we're right on top of. And so there's a couple options here that are wrong. Fluoroquinolines, again, we talked about the controversy with kids, but really that would be for a pneumonia if you're going to use it at all. And this isn't likely. I mean, could be, but probably not pneumonia at this point. We're probably looking at a bacteremia at this point, possibly leading down the road towards sepsis. Augmentin is an oral medication, which of course wouldn't be appropriate in this patient. And you're left with 2. So we talked about Vanco, not needed for this particular case. So that eliminates D. So C, kind of by process of elimination. And then that's really what we're targeting. So group B strep, you're usually giving ampicillin or penicillin because you got a guaranteed coverage with that. Cefotaxime is recommended as an add-on too because it covers other gram-negative things. It also gives you some synergy and will cover group B strep as well. So you're hitting the group B strep from 2 sides. You're also picking up some of those gram-negatives. So C would be the correct answer here. And then the final question, AS, 2-month-old girl, recently had surgery to correct her transposition of the great arteries. She is post-op day 1 and doing well. Her blood pressure is stable, but her cardiac output is lower than desired. Which of the following would have a positive inotrope effect with minimal change in blood pressure? So this is taking us back a little bit to our cardiology lectures last fall and just understanding some of the pediatric medicine we see a lot. So we've got a basic group of pressors here, and also well, let's not, pressor is probably the wrong term. Let's say hemodynamic agents. That's a more broad category, right? So anyway, dopamine and epinephrine are pressors, which means what? They're going to change blood pressure. So that's what we don't want to do. So A and B are automatically ruled out here because they would have an effect on blood pressure. Nitroprusside is wrong for 2 reasons. It's not a inotrope, and it would actually cause a decrease in blood pressure, which we don't want to do either. It's for hypertensive emergencies. Milrinone is the next medication, and that is basically just a pure inotrope. It doesn't really have a lot of effects on blood pressure. It's exactly what we want to do. So just keeping in mind what we're using for some of these cardiac emergencies, and that would be the drug of choice here. So that's it. A couple other things just to think about when you're studying. There's some information on the test. Again, we kind of talked about understanding the general concept of when to start birth control. So I'll give you a scenario, and you'll have to figure out which one of the ones is most appropriate for the patient. And again, if you kind of understand the general concept of there's either backup contraception or you're starting during the menstrual cycle or at the beginning of the menstrual cycle and you don't have to use backup contraception, those are really the 2 options when you distill everything down. So just keep that in mind and check out that chart, especially the last part of it in the PowerPoint if you're confused on that. Understand emergency contraception, when it would be appropriate to use. So if you had a patient call you and said, hey, I missed a dose or 2 doses or 3 doses of oral contraceptives, what's the best plan for that? So know those. And everything else is probably pretty straightforward as far as my standard test questions and standard material coverage. So that's all I've got. Again, if you have questions in the next couple of days, feel free to email me, but I'll see you guys on Monday. Thanks.